speed the case a little bit up.
What's the diagnosis?
We will see. So let's go. This is the story of a 21-year-old man who presents with fever and rash. He has fever since 1 week, and it is associated with headache, myalgias, nausea and vomiting. Today he woke up and noticed a rash in his face, torso and extremities. And that's it for the first aliquot. He couldn't tell if the rash started on his palms or his torso. He just woke up and had a generalized rash.
All right. Well, I will just be very brief with us. A young person who's presenting with fever and rash, the first things we have to worry about is making sure that we're ruling out the life-threatening causes of fever and rash together. And that's going to include things like disseminated infections like meningococcemia, potentially drug-related issues of fever and rash. For example, things like Stevens-Johnson syndrome or TEN. We don't necessarily have a background medical history or exposure history to certain medications, but we will have to think about that. Other things that we have to keep in mind are things like toxic shock syndrome. If he has the right geography and epidemiology, we'll think about things like Rocky Mountain spotted fever, and then also endocarditis is in our sort of life-threatening causes of fever and rash DDX. The other things that we can lump into the fold immediately when thinking about a young, what seems to be a relatively healthy person is going to be something like a viral exanthem. These are going to be things like that can cause a mono-like syndrome, including EBV and CMV. And the one thing to not forget about in any young person who's coming in with fever and rash is to test for HIV, but just reflexing to our general HIV test is may not be enough. Our classic HIV antigen antibody test will catch individuals who may have been exposed to HIV around 2 to 3 weeks ago, but you can have a sort of the acute retroviral syndrome within the first 7 to 10 days after seroconversion. And in those cases, you may still have a negative antigen antibody test. And so an HIV PCR may be crucial here. But I think what we're really going to do is sort of hold our breath, make sure that we're not missing one of these life-threatening causes, get an understanding of this individual's risk for HIV and test for it if the risk is there. And after we've moved through that initial framework, I think thinking about how we can be more systematic and methodical as we move through the rest of the fever and the rash schema. But I'll turn it over to Charmaine to add anything else there.
Is there anything to add? Nope. That was absolutely beautiful. I love that approach. And I think thinking about life-threatening causes, always having that in the back of our mind as we go through the case is so important. And as just to kind of like summarize what the amazing Jack Prenner is saying. So basically, our bucket after life-threatening causes, you want to think about infection, the drugs, a malignancy and autoimmune. In a young person, again, malignancy will be lower, and the time frame kind of prioritizes infection in addition to the other life-causing malignancies. However, we need more information. And I think with rash in general, I like the approach of I'm very simple, thinking about is it an inside job or an outside job? Thanks to the great Curbsider episodes on that. And, in our world of internal medicine tends to be more inside job. So can't wait to hear more about the background information and go from there.
Amazing discussion. So let's proceed. He also complains of diarrhea, cough, and dyspnea since the start of the symptoms. He denies photophobia, other pain, syncope, stool or urine changes. He is not on any meds and has no allergies. He smokes 1 pack of cigarettes a day, denies alcohol abuse, has a history of IV drug use, smokes marijuana daily. His family history is unremarkable. He lives in Austria. He was in California though 2 weeks ago. He had no tick. He denied any mosquito or tick bite. He has 2 cats, and this sexually active with multiple female partners and uses protection only rarely. And he works in the chicken production. I don't know how to say it. I don't know, you want to comment on that or proceed to the physical exam?
I'm sure I can take a quick stab at this information. Just to clarify, Sammy, he does have a history of drug use. Okay, perfect. All right. So just kind of like framing again, like it strikes me as someone with no past medical history who, again, in a 21-year-old, a couple of things to think about. One, they don't go to the doctor that often. But it doesn't mean they don't have any underlying health issues that hasn't just come to the surface yet. So gotta have to be always open to, again, like any tail end of like congenital diseases, immunodeficiency that might be presenting itself. Less likely here, good to recognize. And thinking about the HPI as well, I'll just let Jack layer on like the dyspnea and the review of symptoms, and I'll just focus a little bit on the social history here. I think the one thing is that jumps out is someone who has who injects drugs. Again, like a portal of entry. We unfortunately can see bacteremia, endocarditis, a slew of like more chronic indolent infections with people who inject a drug. So something to explore, and also good to get a better history of like how they do it, the supplies they use, to just get a better sense of their exposures, if they're licking the needle or not. Like all of these things like help again getting a better like exposure history for the patient. In terms of like a travel history as well, I'm not going to dwell too much on it, but again, thinking about things that he could have been exposed to in California, where in California would be helpful. And again, in terms of like his exposures, thinking about all the things that comes with having cats at home and also with chicken, again, like your zoonotic infections. I'm not going to dwell too much on it. I think the social history is really rich. But we can layer on and come back to it as we get more information to kind of like weigh this social history against the physical exam and the lab work to see if there's any of these threads that we need to go deeper on. Jack, any other thoughts?
No, I am right there with you in terms of thinking about how we are going to prioritize the evaluation here. And I think it's a brilliant point that there's lots of sort of shiny objects in the social history, but from a probabilistic standpoint, we have to think through the complications of IV drug use, like you mentioned, and also think about what this individual's risk factors are for sexually transmitted infections, including HIV. And if they are HIV positive, then figuring out where they are in their HIV positivity course to better understand their immune status. But I think I am on the exact same page as you in terms of looking at the injection drug use is probably the most relevant clinical factor right now. And then once we move beyond that syndrome that has higher pretest probability, then we can start to entertain like cats and whatever other rodents they may have encountered in California.
Great. It's so nice to listen to you. I learn a lot. So let's go to the physical exam. His temperature was 38.4 degrees Celsius, heart rate 121, blood pressure was 113/50, respiratory rate was 18, and SpO2 was 92% under room air. He was alert and oriented ×3. He was in mildly reduced physical status. For his hint exam, the conjunctiva were anecteric. His pharynx, there was no redness, no ecchymosis, so basically no pharyngeal. Pharynx was normal, but he had painful submental lymphadenopathy. His cardiovascular exam, pulmonary exam, and abdominal exam was unremarkable. On his skin, he had a generalized maculopapillose exanthema on the face, torso, and extremities, also including the hands and the feet, so the palmar and the plantar aspects. and petechiae on the lower extremities. For his neurologic exam, he had no focal neurologic deficit and no meningism was noticed.
All right, thanks so much, Sammy. I will talk through maybe some of the findings that we have on the vitals and some of the upper body exam findings, and then I will kick it over to Charmaine to talk about these findings that we have on the skin exam as well. But I think if we sort of just now think about how we can now take a step forward, I think we're better able to characterize the syndrome that this individual has, and we can now characterize it as a more systemic illness that has cutaneous manifestations, but also a tropism for the lymphatic system. If we look at the categories of disease that Charmaine took us through in our first approach to fever and rash, we can see that all of the things on this list, right, infections, drug-related issues, malignancies, or autoimmune diseases, including connective tissue diseases and vasculitides, they can all manifest with acute systemic illness, as well as findings of lymphadenopathy. I think what our task is going to be here is to decide whether or not this submental lymphadenopathy is an ice flow, right? Is it just a single piece of ice floating on top of the water, or is it actually the tip of the iceberg and there's much more lymphadenopathy underneath? Acute cervical lymphadenopathy in the setting of a systemic illness is completely compatible with an upper respiratory viral illness that could be manifesting with a viral exanthem. Like, that is one very plausible hypothesis. But then we also have to entertain the fact that what we're feeling and palpating in terms of the lymph nodes is actually just the tip of the iceberg, and we're dealing with more of a generalized lymphadenopathy syndrome, which could be one of the mono-like viruses like EBV, CMV, or acute HIV, or it could potentially be a different type of disseminated autoimmune disease, for example, connective tissue disease like lupus. But I'm going to leave it to Charmaine to sort of take us through how these findings of the petechiae are potentially influencing how we're thinking about the lymphadenopathy here.
Lovely, Jack. So kind of like pick up the thread with Jack and thinking about kind of like someone who's inflamed with cervical lymphadenopathy and what appears to be like a systemic rash with some petechiae on the lower extremity. Petechiae in the lower extremity, sometimes with like petechiae, we think about like, platelet disorders, although, some people can have it without having the disorders. So we'll see if that becomes more irrelevant or not. But thinking about like kind of the systemic rash, and I'm someone that, to be honest with you, derm is not my strong suit. So I'm always grateful for Gabriel for being here. And I'm so glad he's doing teaching points, because I'm sure we're going to learn a lot from him. But I kind of will focus on my own strength, which is like, okay, thinking about more systemic, like medical issues that can have presentation with rash and comparing and contrasting them, right? As Jack mentioned, like, our viral diseases like EBV, CMV, definitely HIV, it can definitely do it. CMV less. And in terms of like thinking about the things that would be the most concerning with this patient, it would be kind of like a bacterial pyogenic infection, and it requires like more urgent. He doesn't have any dental issues that we've noted as well. By thinking about like, group A strep, again, less likely here that can do it. The thing that also Jack mentioned previously is like your STIs, right? Like, thinking about gonorrhea specifically that can have a rash associated with it, but also syphilis is something to think about. Again, it could be secondary syphilis. However, I still think like given how degree of the inflammation, and labs would be really helpful, but something to think about with this patient. And then, I think with fungal and everything, tend to expect a little bit more indolent. However, we still don't know the immune status of this patient who has like multiple risk factor to be immunocompromised. In this age, don't want to forget about, my nemesis. By nemesis, I mean because I always like forget about lupus. And, I'm just going to put it out there instead of like, he's a young patient, autoimmune disease is something that I'm thinking about that can have a rash as his manifestation as well. And there's a bunch of like less common diseases like Kikuchi Fujimoto that you have to think about with cervical lymphadenopathy and someone coming inflamed. Rash tends to be a little bit less likely presentation. They don't tend to always have a rash associated with those things. And liquid malignancy would be the one that I worry about that can have systemic kind of rash as well. So I think going forward, thinking about our labs to see if there's anything a pivot point there for us. But again, still like pyogenic bacteria is the one that we want to rule out first, and then thinking about more viral etiologies and autoimmune is where my brain is at. Anything else, Jack?
No, I was just searching for the fire emoji to display. I have nothing to add. And I found it.
Amazing. Okay, so let's go to the labs and some imaging. So leukocytes were 6,400 with 78% neutrophils, 16% lymphocytes, and 5% monocytes. Hemoglobin was 15.3, thrombocytes or platelets were 99,000. BMP, sodium was 133, potassium 3.5, chloride 103, bicarb 22, creatinine 1, glucose 99. For LFTs, AST was 58, ALT was 12, Billy was 0.4, alkaline phosphatase was 78. His urine analysis was within normal limits with a specific gravity of 1.020. His chest X-ray demonstrated prominent interstitial markings without a clear infiltrate, and his mediastinum was not dilated, so normal. His echocardiography was basically within normal limits, good systolic and diastolic function. The valvular apparatus was within normal limits and normal dimensions of the cardiac chambers.
All right. Also, I just want to shout out Angelita for looking at that SpO2 a little bit more thoughtfully than I just completely glanced over. And you're right, 92% on room air is a little low for a 21-year-old. So that's something that you absolutely want to investigate a little bit more. You're absolutely right on that. So thank you. So I like to walk patients to make sure if they're actually hypoxemic or not, make sure the wavelength is good. And if it's a true hypoxemia, we have to think a little bit harder about that. So thanks for pointing that out. Crowdsourcing is the best. So kind of, how about like I'll focus on this CBC and then see what the amazing Jack has to add to that. A white count that is normal, again, depending on like underlying someone's immunostatus, I used to think like, all infection inflammatory should have leukocytosis. And I have been humbled by medicine that, a normal white count in the setting of an inflammation, when the patient's already telling you inflammation, doesn't make infection, doesn't make any of this less likely in my mind. One thing that is notable on the CBC is a low platelets. So thinking about, again, coming back and connecting that to the particular that we were worried about and thinking about thrombocytopenia as an etiology of it. And with the thrombocytopenia, you think about like, is the platelets are getting destroyed? Are the platelets getting sequestered? Is it a beginning of a bone marrow etiology? And with the thrombocytopenia, every time you see it, you want to hold your breath, make sure like, are you worried about MOHAs? With a normal hemoglobin, probably less likely. Or has this person's been has had heparin? Again, like probably this is the first time this patient's getting in contact with the healthcare system for a while, so less likely that he's gotten heparin exposure. So those are the two big things that I think about, and then thinking about in infectious etiologies that can do burst the cells, thinking about like ITP type against like antibodies against the membrane that can do it. So not worried about any of those crazy things like HIT and MOHAs. Again, thinking about how we can possibly relate this to an infectious etiology. Jack, what are your thoughts?
I completely agree with you. I think if we were to sort of like then layer in or take what is happening as you brilliantly articulated in the bone marrow, and then also layer in these findings of the chest X-ray, a lot of the things on the list that we talked about of sort of acute infections that can cause fever and rash, or even many of the autoimmune diseases that can cause fever and rash, they're not all necessarily going to potentially give us pulmonary manifestations, right? Disseminated, we talked about how EBV and CMV could give us the findings of fever, rash, and lymphadenopathy, but I wouldn't necessarily think of them about something that could cause a pneumonia. If this person were to be 81 rather than 21, it's totally plausible that they could have some degree of HFpEF that could lead to pulmonary edema. But in the setting of a normal echo and interstitial markings in a young person who has a systemic illness, we have to think about how we can bring a possible pulmonary infection into the fold here. And so I think thinking about of those mono-like syndromes that can do it, CMV can cause a pneumonia, but it's usually in individuals who are profoundly immunocompromised. EBV doesn't oftentimes cause pulmonary manifestations. It's usually going to be upper respiratory tract. If we get into the HIV picture, it gets a little bit more confusing because we are talking about the acute retroviral syndrome, but most of the pulmonary complications of HIV are going to be late stage, either related to opportunistic infections or things like HIV-related interstitial lung disease. However, it's not impossible for individuals to get an opportunistic infection during the acute retroviral stage of illness because there is a big drop in CD4 count alongside this big spike in viral load that's responsible for most of the symptoms. And so I think until we get that HIV test, I'm very much wondering, are we dealing with acute retroviral syndrome that's either just having this sort of non-specific pulmonary disease? Are we dealing with acute retroviral syndrome in the setting of somebody who may have a rare opportunistic infection early in their course? Or actually, has there been undiagnosed HIV for quite some time now, and we're seeing some of the later stage opportunistic infections? I think the fact that we have the profound thrombocytopenia without the anemia maybe makes a more chronic illness less likely, but I think that is certainly something that's coming to mind. But then we also have to be open to the fact that the chest X-ray findings are completely non-specific and unrelated to everything. And I think in that case, I have nothing to add to the DDX you laid out before, including the infections, but also the autoimmune diseases. So I'm super excited to see where the final diagnosis ends up, because as always, Sammy has left me feeling somewhat stumped.
I love that. The only thing I would also add is like blood cultures. I'm still like, the sepsis, any bacteremic type things can also cause low platelets. So common things being common. Thinking about that too. That was beautiful, Jeff.
Okay, great. So blood cultures were drawn and were without growth after 5 days. A lot of serologies were drawn, which were all negative. So CMV, hepatitis B, hepatitis C, HIV, influenza, RSV, rickettsia, dengue, chikungunya, West Nile, toxoplasmosis, and an STD screening was also negative, so negative RPR, gonorrhea, and chlamydia panels were drawn and were all not normal. EBV was consistent with past infection, but he had an EBV PCR which showed 13,200 copies. And the next aliquot will reveal the final diagnosis.
All right. Well, I am just scanning this to see what exactly we have potentially missed or not. I'm not sure how I can actually understand, or I'm not sure what to exactly make of the PCR that is having that high of copies. I would expect somebody who has a prior infection would not have a substantial viremia like that. And so I think the EBV PCR being positive, one hypothesis is that this is all just disseminated EBV. The other possibility is that there is something that has led to an immunocompromised state that is leading to a reactivation of underlying EBV. ways that can happen in a young person, and any sort of alternative acute infection can lead to a reactivation of a sort of chronic silent infection. Another thing that can do it is we can have EBV-associated lymphomas that can lead to the reactivation of EBV viremia and be associated with a new diagnosis of lymphoma. One question that I have for Sammy is whether or not the HIV was an antigen antibody test or a PCR, just going back to always remembering to not forget about the window period where you can have PCR positive, antigen antibody negative testing, and that can sometimes lead to a delayed diagnosis. But I think I'm sort of wondering here, like, we can potentially explain this all to the EBV alone, but I think before we center on that diagnosis, we have to exclude an alternative immunocompromising state, which could be any sort of new acute infection, although many of those have been tested for a new underlying autoimmune disease like lupus, as Charmaine mentioned, or in rare but certainly possible cases, a new underlying malignancy, with which in a young healthy person with lymphadenopathy, we have to think about lymphoma. Charmaine, what are you thinking here?
Yeah, so I completely agree with you. I was just like thinking through the EBV as well, and with EBV is like super tough because any like infection, anything that really anything that like basically really challenges your immune system can cause reactivation, at least like the IgM. It can cause a strong immune activation and lead to detectable, I think, the VCA IgM levels. And if there is but the negative ABV, and usually in those settings, you get a negative ABV PCR. So the fact that it's positive, at the it could be disseminated EBV. I'm not 100%. Honestly, I'm not. I don't know. I don't know what's going on here. But I think like ABV is a good thought. The other things to think about, again, like kind of thinking about if this is not EBV, or what else could it be? Infections that we're missing. Again, like people with like cervical lymphadenopathy, I think in general, getting a better sense of whether that lymphadenopathy is only cervical or you can see it in other places, right? Like if the patient has splenomegaly, if the patient has more generalized lymphadenopathy, that changes your calculus a little bit. And just not to anchor on the EBV. And the reason why I ask is that in these cases, sometimes if you're puzzled, sometimes like getting the lymph node biopsy earlier than later, it can be helpful. And that is like one like pearl to remember, especially if you at any time you consider a disease like Fujimoto, is that because it kind of mimic in any of these, and usually people get $1 million workup for them, and however, like a biopsy would have been helpful in what for treatment, for like prognosis wise, treatment wise, and also workup wise. So I think EBV it's positive. However, I'm not 100% sure you can explain all the things. So I'm very curious to learn from Sammy. I don't know. I'm just like babbling on. Jack, any other thoughts?
Nothing to add. I think it's hard to really put with any degree of confidence a specific label, but I think I'm right there with you with the different hypotheses that we have.
Amazing, you guys did so great. It's, as Jack said, hard to make a diagnosis now. So the EBV was consistent with past infections, so the EBNA antigen or antibody was positive, but he still had the copies. HIV test was a 4th generation test, and also PCR was done, which was also normal. What actually returned positive were measles antibody, IgG and IgM. And it was thought he wasn't vaccinated, and it was thought that he had acquired it during his travel. And yeah, just a reminder to always think about measles, and I will mark it at 2 minutes after we started, as Nilayan was thinking of it. So really nice. And it was an amazing discussion, and just an important reminder to think of measles. We all think that it's not that common, but when somebody presents with maculopapular eruption, it's also called morbilliform, and people use this term, but I didn't think of measles when I read this case. So yeah, I just wanted to share it. And I think we all learned a lot. So thank you for this amazing discussion.
That is so awesome. What a great case. I love it. I love it. I think this is the second time that we had like the humbling moment of realizing how quickly vaccine preventable illnesses can fall out of our head.
Oh, 100%. Such a wonderful case. I don't think about measles, to be honest with you, working where I work at all. So this is fantastic. Yeah, you're absolutely right. I think like I was like, oh, it doesn't quite fit with EBV. But I was like, measles. Fantastic. So this is such a great learning opportunity. Thank you so much, Sammy. I can't wait to refresh my memory about measles and think about it next time. So always thinking about kind of asking about vaccination status. I know sometimes it's quite a hot topic of the day these days here, but always important to know. Sammy, you're awesome. Jack, it's always a pleasure. Sammy, any other thoughts before we give the mic to Gabrielle?
No, just the reminder, because Hans said in the chat, did they look for Koplik spots? And Koplik spots usually form before the exanthem. So when you have the maculopapular eruption, the Koplik spots are usually gone. So this doesn't exclude it. And ask for vaccinations.
Beautiful pearls. Heather, thank you so much for scribing. Thank you all for joining us. I can't wait to learn more from the one and only Gabrielle.
Yeah, excellent case, Hami. And it remembered me that I have one pair that in pediatric patients, well, this patient is not very much pediatric, but when you see a rash in pediatric patients, actually you don't think it's syphilis because it's not very much common, but you can think in two things: Kawasaki if less than 5 years old, and measles. So that two diseases are actually high on my differential when I see pediatric patient with rash involving the hands. So yeah, for starting the teaching points, first we have a young patient with fever and rash. So the first thing we want to do is rule out emergency conditions such as Stevens-Johnson, toxic epidermal necrolysis, purpura fulminans that can cause by very conditions such as DIC, meningococcemia, etc., toxic shock syndrome, enterocarditis, Rocky Mountain spotted fevers. And also, what can we link the age in this shift complaint is that usually young patients with fever and rash, the main differentials are viral exanthems, Epstein-Barr, acute retroviral syndrome for HIV. And also we want to look for clues because rash can be very non-specific and also fever. So we want to know about if there's any associated symptoms that can help us to make a final diagnosis or inquire about certain expositions such as recent traveling, drugs, or sick contacts. Also, we want to characterize the rash because there are some characteristics of the rash that can help us to make our differential diagnosis, such as if we see hives, we can think of urticaria or pustules, psoriasis, AGIP. If we see vesicles, bular eruptions, we can think about varicella and other viral exanthems. And don't forget about Stevens-Johnson. And if we see petechia and purpura, we can think about viral exanthem, vasculitis, Rocky Mountain spotted fever, meningococcemia, etc. And in this case, for example, morbilliform and morbilliform pattern that stands for confluent macules, we can think about measles. So then we were collecting clues. For example, if we see this kind of pattern of acute systemic inflammation and rash involving the hands, we're thinking about secondary syphilis, Coxsackie, some types of psoriasis can also affect the hands. Rocky Mountain spotted fever absolutely can. Rubiola, measles, don't forget about that one. And ask for vaccination history. and erythema multiforme. Maybe if were targetary lesions that can help us to think of erythema multiforme. And so then the patient also presents with interstitial markings. So we were thinking about acute retroviral syndrome, viral exanthem, or a complication of IHIV as Jack taught us. And then some measles pairs that usually the rash in measles appears or starts appearing in the ending of the fever, and it involves also the hands. So thank you so much for connecting in, and see you tomorrow. Happy birthday, Robbie.
Happy birthday, RG. Yeah, this is Sammy. This is like the perfect gift for Robbie. I think he will really enjoy this. Okay. Thank you all so much for joining us. Thursday is always a treat. Thanks, Jack. Thanks, Gabrielle. Thanks, Heather. Thanks, Sammy. I can't wait to see you all tomorrow. Bye.